excited about this. I'm going to cover very briefly just a little bit of housekeeping about how this session will go. There are full videos for each of the presenters that are available at the link on the screen. For this session, each presenter will cover a few slides of their research. They'll have about 2 minutes to do that, do an overview of their e-poster, and then the faculty facilitator and their colleagues will pose some questions to them for the remaining 8 minutes. So each of these rapid fire presentations will have a total of 10 minutes, 2 minutes for presentations, and then 8 minutes for some Q&A. You may have noticed I had a slide of a memorial or monument in DC. I will be using those as a cue that there's just about 30 seconds left in each of these rapid fire presentations. So we'll move into that. The first group of the rapid fire presentations highlights 2 of the AIR-P research nodes, the health systems and services nodes and the primary care and quality nodes. And I'm grateful to Elizabeth Morgan, Dr. Elizabeth Morgan, for serving as a faculty facilitator today. She is a program coordinator and a mentor at UC Davis Mind Institute.
Right, thank you very much. I'm very honored to be able to introduce our speakers for today. So we're first going to, the way that our sessions are going to go, there will be 2-minute sessions that the speakers will be given, then followed by an 8-minute question and answer session. So our first speaker will be Alice Bravo, and she is coming to us from the University of Washington Center for Human Development and Disabilities. So I'll turn it over to Alice.
Thank you, Dr. Morgan. Hi, everyone. My name is Alice, and I'm a doctoral candidate at the University of Washington and an early childhood educator and behavior analyst by training. And I'm excited to be discussing some joint work between the University of Washington and Seattle Children's Hospital on Project ECHO, building primary care capacity for autism diagnosis and care. Next slide, please. So clinicians and researchers at the University of Washington and Seattle Children's Hospital have piloted and continue to run a telementoring program for primary care providers across the state with the goal of increasing community-based PCP capacity for autism diagnosis and ongoing care while reducing family and individual wait and travel time for accessing this care. And we've been doing this program using the ECHO model of telementoring, which was established by the University of New Mexico and uses case-based learning and didactic presentations using Zoom. Next slide, please. So with our first cohort in 2020, we simply examined changes in participating PCP self-efficacy levels and reported barriers related to providing autism diagnoses and providing care. Next slide, please. And we did this by sending out a survey to our ECHO participants pre and post the one-year program, which included a measure called the Primary Care Autism Self-Efficacy Survey and included questions about practice barriers. Next slide, please. We had about a 68% response rate for both times 1 and 2 and saw a significant increase in overall PCP self-efficacy levels related to autism diagnosis and care. Next slide, please. And we also saw a decrease in PCPs reporting a lack of prior training, a lack of knowledge about autism symptoms, and a lack of confidence in managing challenging behavior as barriers to providing autism-specific care. Next slide, please. So we're very excited about our next steps to further and more rigorously evaluate this autism in primary care telementoring program. One next step is to include a comparison group of non-ECHO PCPs in Washington state to further evaluate changes in self-efficacy over time. And another next step will use AIR-P funding to evaluate ECHO PCPs' care recommendations given to newly diagnosed individuals and compare those with recommendations provided by more seasoned clinicians from an autism specialty clinic. And we will also follow up with these families 1 year post-diagnosis to better understand access to services at that time based on recommendations they've been provided and family satisfaction with the diagnostic process. So I think I might have gone a little over time, but I look forward to continuing this discussion.
Wonderful. Thank you so much, Alice. So I'm going to go ahead and start the questioning. So I'll start with a question, but for any of those who are interested in asking your question, please type it into the chat and I'll make sure to read it and we will address it right after. So the first question is, as you know, the mission of AIR-P is to develop a robust research infrastructure that will foster measurable improvements for in optimal physical health and well-being for autistic individuals and their families across the lifespan. So based upon the work that you have done and will be doing with the PCPs and the Autism Echo project in Washington, I'm wondering what are some of your preliminary ideas on how this model can be used to be able to really address some of the disparities in access to diagnosis and care from children from marginalized and minoritized communities, such as children that live in rural areas, children from immigrant communities, and children of color?
Yeah, thank you for your question, Dr. Morgan. So just for some additional context, the work that we're doing with this Echo Autism program is in some ways a replication of another Echo Autism program by the University of Missouri and the University of Virginia. And we have been connecting with those practitioners and researchers who are running those Echo programs to kind of further share ideas and strategies and what's working, what's not working, and kind of continue to improve this model. And some of the measures that we're using to evaluate our model is measures that they are using as well, so that we can kind of continue to build on this echo literature around telementoring. One of the big kind of, I suppose, impetus behind doing this telementoring program is to be reaching families and individuals who are living in more rural areas and locations in Washington State, who often are on lengthy wait lists and have extensive travel times to get to Seattle Children's Hospital to access a diagnosis, which they then might need to actually access care. And so one of the kind of big goals of this model and approach is to provide training to primary care providers who are working in locations that might be under-resourced when it comes to other providers to collaborate with, to connect with, to provide referrals to. And so we're hoping that by increasing kind of localized primary care provider capacity, we can increase access to diagnostic evaluations by providers that families already have a relationship with and will continue to come and receive services from on an ongoing basis, rather than from an unknown medical provider that is a ways away, will be seen less frequently, et cetera. And so that's one of the primary goals. One of the things that we're seeking to understand, we've been evaluating this model so far just at the provider level, seeing about confidence levels increasing. And so we don't yet know, is this actually impacting outcomes for families and autistic individuals? And so we are hoping to kind of tease apart some of the differences in timelines to accessing services and satisfaction with the diagnostic process across communities of color. And so that's some of the data that we're hoping to collect in our next iteration.
Wonderful, thank you. So we have a question from Alice and a few, so I'll read off the first one. How did you get the PCPs to buy into this?
Yes, that's a great question. So in Washington State, primary care providers, in order to be able to provide an autism diagnosis, have to go through what's called the Center of Excellence training, which is, I believe, about a one-day training. And it has been found that many individuals who have this Center of Excellence designation still are not feeling equipped to provide autism diagnoses and are not providing autism diagnoses or those services. And so there's kind of this established need in Washington State for further training for providers to feel confident in providing services to the autistic community. And so with that, this was all voluntary. There is a COE, Center of Excellence listserv and contact base. So this first cohort that we had of PCPs participating were all contacted and voluntarily participated from the COE listserv. And so we're continuing to expand the number of providers that were able to incorporate into the ECHO model. We now have 2 cohorts running simultaneously. We're kind of hoping for word of mouth and for the participating COEs to help us disseminate the benefit of participating to their colleagues and to other PCPs. But really, we're relying on the Center of Excellence listserv to help us reach primary care providers. We are funded currently through the Washington State Healthcare Authority. There is kind of this interest at the state level in further boosting capacity at the primary care provider community level for this work. And we're also well connected with what we have across Washington State called SMART teams, which are a collaboration in some smaller communities between schools and mental health providers to try to, medical providers to try to collaborate to provide fuller and more informed diagnostic evaluations, again, in communities where more specialized care might not be readily available. So we have a lot of stakeholders kind of invested in the current ECHO program who are attending the meetings as well. And so we're hoping that some of that additional involvement will help us disseminate this opportunity to more PCPs across the state as well.
Wonderful, thank you. And you answered that very thoroughly. So we got all of those Alice's questions in, so that's wonderful. We just have, I think, just a few more minutes. I have one additional question, and if anyone else has any, I'm sure if you type them in, Alice will be able to respond to them via chat also if we can't get to them before the next session. But what do you think when it comes to your study, there was one particular finding that there was the greatest increase in self-efficacy for PCPs under the subscale when it came to this managing psychiatric symptoms. I thought that was pretty interesting. So do you think that had anything to do with the way that your didactics were set up or the facilitators that were a part of your ECHO? Why do you think that came out so dominant?
That is such a great question. And I feel like my answer will be fully speculation. But I imagine that part of it might have been the way that the didactics were set up. We have all of the didactics are run by an expert from our hub team. And we do have a neurologist who's kind of spearheading the program, a clinical psychologist, we have an autistic adult, we have a family resource coordinator and a parent. And I can't necessarily say exactly what it was about the didactics, but I think it was the didactics that delved a little bit more into that content rather than the cases that we were discussing. So I don't know that I can speak too much to the why behind that, but I think it was kind of an interesting and slightly surprising, I think, piece, especially since so many of the cases we focused on tended to skew towards the younger age range in the beginning, since I think those were the cases PCPs felt a little bit more comfortable bringing to the table at the beginning.
Thank you. Well, as you can see, you have a few other questions that have come into the chat. So please, if you can, address those via the chat. And we are going to have to transition into our next presentation. Thank you so much, Alice.
Thank you.
Okay, so our next presentation will be from Belinda O'Hagan, and she is coming to us from the Boston Medical Center. Belinda, you have the show.
Hi everyone, my name is Belinda O'Hagan. I'm a research coordinator for the Autism program at Boston Medical Center. It's basically a family resource support program under the Division of Developmental and Behavioral Pediatrics. Next slide, please. So today I'm going to be talking about one of the latest interventions that we have under the autism program that we are under the in the process of evaluating. So to support autistic patients during their hospital visits, we are currently utilizing autism resource specialists. So autism resource specialists are full-time autism program employees who provide direct support to families. So traditionally, their roles include providing support for families who are trying to access like behavioral therapies, speech therapies, IEPs, basically resources related to diagnosis of autism outside of the hospital. Now, recently, we are trying to expand their role to also include supporting families within the hospital. So their roles include coordinating with families and clinicians to prepare for an upcoming visit, developing tailored resources if needed, being there in person to actually support the patient, and conduct debriefs with families and clinicians. Next slide, please. So our goal is to examine how hospital visits supported by an autism resource specialist is received by autistic patients, their families, and their clinicians. Next slide, please. So first, so this is the methodology being described chronologically. So before the visit occurred, we conduct a pre-visit interview with the caregiver and or the patient, together based on information about what they need. And then during the visit, the autism resource specialist will provide in-person support and conduct a visit observation to identify frequently used strategies and assess their usefulness. After the visit, we'll conduct brief clinician online survey to ask about the visit and about basically the acceptability of that service. We also will do a brief patient survey and a post-visit caregiver interview to get more in-depth information. Next slide, please. So we are currently in the process of developing the study measures and procedures, with plans to begin data collection in the coming months. And findings from this study will be used to improve our support model and to implement this on an even larger scale. Next slide, please. And thank you so much. Here's my contact information on this slide. If you have any questions, I'm happy to take them.
Wonderful, thank you. So I am going to go once again, start us off with our questions. And for those, please type in your questions and we'll make sure to address them. So Belinda, when it came to the rollout of this program, I'm really interested in knowing more about the process that happened in rolling out this to all of the Boston medical physicians, and how to be able to access the ARS.
Yeah, definitely. So currently the mechanism is we advertise this service to all Boston Medical Center clinicians, and we say that any Boston Medical Center clinician can refer their patient to us if they need support. So right now we are getting clinician referrals. Once we have this, more solidified, more standardized as part of our standard care, the goal is we want patients and families to also be able to self-refer, so that they don't have to go through their clinician if they need this service from us. And I also want to add that the Autism Resource Specialist support is free of charge for all families. So I'm seeing in the chat, so there's a question, who funds the ARS and how is it sustained? So ARSs are full-time employees of the autism program, and the autism program is 100% philanthropically funded. And so we fund it through grants and donations as well. There's a question, what credentials, backgrounds, and real-life experiences do ARSs have? So the two ARSs that we currently employ, one of them is a certified early interventionist, and then so that's their background, and then the other one is a board-certified behavior analyst.
Wonderful, and thank you so much, Belinda, for stepping in there. I couldn't unmute for a second, so that's wonderful. So you did answer that as far as the credentials, but do you think when it came to choosing the ARS and even the expansion of your program, will you think about lived experience as being also something that you want to look for, whether it be autistic individuals or family members of autistic persons?
Absolutely. That is definitely life experiences is definitely something that we value in whenever we are looking to work with anybody, whether it's a full-time staff or an intern with our program. That's definitely something that we value. In fact, our program, we have a couple of boards where we specifically seek input from autistic patients and family members, or say like we seek feedback from hospital staff who are themselves family members of autistic individuals. And we always take into account their input when we are developing these services.
That's wonderful to hear. That's actually my next question, which has to do with the feedback that you've gotten from providers. You did talk about in your presentation the feedback from participants, but did you collect any data about the experience of the model from providers? And does it give any information about the value added that the ARS provide to not only the provider, the staff, but then also the hospital, whether it be reducing costs and things of that sort? Do you have any data on that?
So we don't currently have data on that yet, because like I said, we are still rolling out this study, but we do plan to ask those questions as well. We are looking to basically asking feedback from clinicians about what they think about the service in general, and making it part of their standard care. And we are also we are always continuously trying to find outcomes that we can track kind of from the back end through chart reviews, so that we can look for clinic level outcomes as well.
Wonderful, thank you so much. I think we might have answered all of the questions that are in the chat. So this was wonderful. Thank you so much, Belinda, for your presentation. And if anything else comes up, please type it in, and Belinda will make sure to address it in the chat. Okay. Thank you. All right, moving on. So now we're going to hear from Dr. Jessica Kennard, and she's coming to us from the University of North Carolina, Chapel Hill Center for Human and Development and Disability.
Thank you. Thank you for having me. So I'll be talking with everyone today about the development and piloting of a remote assessment for Latinx infants and children at high likelihood for developmental disabilities, including autism. Next slide, please. So we know there's lots of barriers in the Latinx community for getting an autism diagnosis, and that there are disparities at the age in which kids get this diagnosis. And one possible solution to the barriers, such as those listed here, is telehealth. Next slide, please. The telehealth procedure that we're studying in our group is called PANDA Box. That stands for Parent Assisted Neurodevelopmental Assessment. This was developed at Purdue University with English-speaking families. And the way this works is the families receive the PANDA Box kit in the mail, like that pictured here. The clinician observes the family over the computer and guides the parent through these activities with their child. And we're able to look at a number of developmental domains, including signs of autism. Next slide, please. So the aims of our study are to look at this in Latinx culture and with the Spanish language. So our first aim is to translate it and adapt it. And then our second aim is to assess it in a group of families from Latinx culture who speak Spanish. Next slide, please. So for the first aim, we are conducting interviews with Spanish-speaking members of the community, and between each interview, revising the protocol. Next slide, please. And for our second aim, we're currently recruiting Spanish-speaking families who have infant siblings of children with autism. We complete a LENA recording, which collects language data. We walk the family through the PANDA Box activities. We complete validation assessments to check on the outcomes compared to other measures that exist. And then we conduct qualitative interviews with the families to get additional feedback about how this process went for them. Next slide, please. And our next steps are to use funding we received from the AIR-P program to expand this work with infants and toddlers who were identified as showing signs of autism through a community screening. which is important given that many children with autism do not have an older sibling already diagnosed with autism. Next slide, please. And that is our project. I'm happy to take any questions.
Wonderful. Thank you so much. So I'll start it off once again with our questions. So I'm wondering, when it came to your first phase and the first objective of translating and adapting the instrument, I'm wondering, have you been able to reconcile if and when the domains within the assessment, so for instance, the parent and child interactions domain that's within the assessment, if they have any type of different cultural implications, right? And so how were you able to reconcile that when translating the tool?
That's a great question. So when we go through these interviews with the community, we basically are reading the script that we would read to the families when we do the assessments, and we're stopping and asking them, tell us what you think about this. Are there any parts that are problematic? And some things that have come up are differences in how parents might interact with their children in Latinx culture. One example being peekaboo, where many of our interviewees are saying this doesn't seem like it's a good match for many Latinx cultures. And so in these interviews, we're needing to add additional questions for future interviewees. Well, what would be a good substitute here for an activity like that? In terms of how you would later code those parent-child interactions, I know many researchers and clinicians observe parent-child interactions for certain kinds of behaviors. I think that's research that's needing to be done to see, well, what are those interaction differences in the style in which parents are talking with their children, supporting their play. That would need to be a definite question to look at in the future.
Wonderful, thank you. And I see you have a congratulations in the chat for your being awarded an AIR-P pilot funding. Congratulations on that.
Thank you.
A question from Felipe says, is the Panda Box in Spanish only for Latinx community in the US? So for other Latinx countries, would it be available?
That's a great question. So an exciting part about this AIR-P funding that we're getting is a component where we have a community advisory board. And the community advisory board is a group of people who are stakeholders and experts in the areas of autism, but also Latinx communities in the United States and also internationally. And so throughout the year that we're working on this project, we're going to get feedback about how we might be able to move this forward to other countries as well. We have members on the board who do a lot of work in Bolivia, for example, and we also have collaborators in Spain and also working with RTI International, who does a lot of work in Latin American countries.
Wonderful. So Keisha is asking, first of all, saying that it's such a need to decrease barriers to assessment. So this is such a great big project. Do you have any dissemination plans once it's validated?
So the nice thing about the Panda Box, Dr. Kelleher, who developed it at Purdue, has a vision that this would be a protocol that would be available freely, kind of a open source protocol. And we would plan to go along with her vision for that and make the Spanish portion available freely as well. She has a nice plan for training providers who would want to learn how to use it, and also ways of maintaining fidelity once you are trained, checking in and make sure you're still administering it to protocol.
Wonderful, thank you. And then I'm wondering, when it came to, if you could just restate the age group that this is validated for.
So for this current phase, we are looking at 3 to 18-month-old infant siblings. For the second phase, when we're looking at children in the community, it will be 8 months to 18 months.
Wonderful, thank you. And the next question, how much does the Panda Box cost for a clinic if they might want to use it?
That's a great question. So there's a paper published on the English-speaking version where they have a cost analysis assessment. And the price of the Panda Box materials comes out to about $2,900. And in the cost assessment, they look at how would that cost, what's the benefit ratio of using that, depending on how frequently you're using it and how many patients you would see.
Well, thank you. And I have one additional question. So when it comes to the study teams that you used, I'm wondering if there were any community members that were on that team when it came to translating, and then that also supported, not only translating the linguistically appropriate, but making sure that it was culturally appropriate information. So did you incorporate community members in that in particular?
Yes. So all of the interviews we're doing about our translation are members of the community. We're recruiting professionals who are bilingual in both English and Spanish and have proficiency in both of those languages, but we're also recruiting parents who may not speak English but are proficient in Spanish and would be able to provide that feedback about the cultural piece. And when we're asking about all the activities, we're not just asking about, does this language sound right? Does it make sense? But also, could you see yourself going through this, and would these activities make sense, or are there things we should be keeping in mind?
Excellent. And then I guess this is an additional question. So what lessons did you learn from this practice, and how has it impacted your center?
I've learned a lot about translation, and I think that when I was getting my dissertation several years ago, I would do translation, and the idea was just to get it professionally translated. And if it was professionally translated, you'd feel comfortable that it was good. But I've learned throughout this process that's not necessarily the case, and it really pays off to really field test the translation with a lot of different members of the Spanish-speaking community, especially because there are so many different countries that speak Spanish with many different dialects and different perspectives about it. So that's one big takeaway.
Wonderful, thank you. And then you can see that there's a comment about a group in Argentina that'd be really interested in using this, and with some contact information. So that's a nice connection right there.
Thank you.
And then asking about the costs, specifically also being a big issue, and how could this project impact that area?
That's a great question as well. So the cost on the clinic side of it would be purchasing the materials. From the patient side of it, the cost of receiving those assessments would be something to consider. It would reduce the cost of their travel burden and potentially needing to provide childcare, but that's something that would be very important to be checking with families about, and how this is impacting them in terms of their time and finances.
Wonderful, thank you so much. All right, so we're going to go ahead and transition into our next session, which will be Dr. Jennifer Ames, and she's coming to us from the Kaiser Permanente, Northern California. Thank you.
Hi, thank you. Yeah, my name is Jennifer Ames, and I'm a staff scientist at Kaiser Permanente, Northern California. And my poster reported on racial ethnic differences in psychiatric and medical diagnoses among autistic adults. Next slide, please. So some background, we know that among children, there are racial ethnic disparities in access to autism diagnostic and support services. Less is known, however, about racial ethnic health and healthcare disparities that may exist among autistic adults. And so this study sought to add some descriptive information to this area. Next slide, please. And what we did is we compared a cohort of autistic adults to non-autistic adults who were all receiving care at Kaiser Permanente. And I'll just summarize a couple findings in this 2 minutes, but we found that autistic adults in blue generally had higher rates of psychiatric conditions compared with their non-autistic counterparts of the same race ethnicity in orange. Next slide, please. And when we looked just among autistic adults, Black adults shown in green and Asian adults shown in light blue were markedly less likely to be diagnosed with psychiatric conditions than their white counterparts in gray. And next slide, please. So the rates of many co-occurring medical and psychiatric conditions, which I wasn't able to show in this presentation, were higher in autistic adults compared with non-autistic adults of the same race ethnicity. though the magnitude of the contrast differed by race ethnicity. And among autistic adults, the rates of some health conditions differed by race ethnicity, and these differences appear to mirror the racial ethnic disparities in the general population. So some future work will examine whether these differences reflect disparities in healthcare utilization and possibly identify targets for intervention. And next slide. And thanks for your attention. And here's my email address, and I look forward to your questions.
All right, wonderful. Thank you. Once again, I will start it off and then we'll look to the chat for more questions. So I'm interested in knowing, so the findings that you had specifically regarding race being a big predictor in disparities for people of color, Black, Brown, Asian, wondering between ASD and non-ASD, what does that tell us in your opinion and in your analysis about current practice and policy that causes and perpetuates racial discrimination within our medical institutions and beyond?
Sure. Yeah, I think, in this project, we were just looking at the rates of the diagnoses. So we weren't able to look at specific, factors contributing, like whether these are disparities or what's going on. But we can speculate that, there's discrimination potentially happening at the healthcare level. And there's potentially, stigma within some of these communities, cultural stigma, especially around, psychiatric conditions. Even though all the people in the study have healthcare, they have insurance, there still may be access issues in knowing how to get referred to a psychiatric provider or something like that. So we do know that these are factors that certainly impact the general population, and sort of this lower psychiatric diagnoses among ethnic racial minorities is something that is seen elsewhere.
Yes, I love that. We could talk for a long time, so maybe I can follow up with that. I love that. So there's a question from Alice regarding mental health access is already difficult for non-autistic patients. So how do you think this could be addressed for autistic individuals?
Yeah, that's a really important question, and something that we know, at least from our healthcare system, and this is certainly the case in a lot of healthcare systems, but a lot of adult providers, primary care providers, don't have a lot of experience working with autistic patients, and so they may not be aware of some of the mental health challenges in this group. And so I think a lot of it is education of providers so that they can better identify and refer their patients to mental health care. And trying to think if there's anything. Yeah, just better screening among this population to make sure they're getting their mental health needs met. Yeah, and Lisa pointed out that we could certainly use some healthcare supports like patient navigators or care coordinators, and again, the provider education.
Excellent, absolutely. And then when it comes to, I'm interested in knowing the type of community-based research or intervention projects that can help address some of these healthcare utilization issues that you had spoke about in your presentation. So what are some, ideas that you have on being able to incorporate those things to address some of the conclusions that you came to for your implications?
Yeah, so I think it will be important to understand whether there's the opportunity for diagnosis happening, because people who are going to their healthcare provider are more likely to receive a diagnosis. And so it will be useful to know whether people are going to the primary care provider at the same rate, because this is an opportunity where they may be screened or may be referred to a specialist, and so we can get a better handle of what's happening there. And I think also it'll be important to understand even treatment among those who do have a diagnosis, to make sure we're not seeing important differences in how treatment is being delivered among different groups. So those are kind of the first, ways I'm thinking about it right now, but open to suggestions.
Yes, thank you. There's actually some work that we've done at Davis where we actually solicited information from the community to ask, the experiences, and heard some really great, got some really great input, just about the advocacy that was happening, but not being heard by our providers, right? And so I think that, there's communication that's happening, but it's not being heeded. And so it's really something to take into consideration as we're developing our plans and our policy and our practice. So thank you very much. If there are any other questions, please type them in the chat. And I'm sure Jennifer will make sure to get to them in the chat. Thank you so much, Jennifer.
Thank you.
Okay, so now we're going to transition to our last presentation, which will be, and I hope I'm saying the last name wrong, right? And if I am not, please correct me. Valerie Takaskali. I could be saying it. Did I say it right?
Yes, that is great. Perfect.
Oh, really? Okay, sounds
Yes.
good. Coming from University of Massachusetts Memorial Children's Medical Center. Thank you, Valerie.
Thank you. Hi, everyone. My name is Valerie, and today I'll be presenting on earlier identification of autism in toddlers with the RapidFire Fast Track Clinics and Telehealth experience. Next slide, please. So the RapidFire is an interactive level 2 ASD screening test. It's easy to learn and can be administered and scored within 10 minutes, and it does not rely on language. We do have manuals and scoring sheets that are translated to different languages, and our kits include pictures of diverse children for representation. We also have validated cutoff scores for the RapidFire. Next slide, please. Our objectives are to study new models for fast track clinics, as well as validate a version of the telehealth RapidFire. Next slide, please. We had a successful pilot with Tome, EI, and Worcester, which we then generalized to other EI programs in primary care. We trained all EI programs in Massachusetts on the RapidFire, and they were linked to diagnosticians in their areas. And then DBP remains as the main referral for Central and Western Mass. Next slide, please. So this graph represents a fast track modeling clinic and how using the RapidFire can really help us differentiate between those who have ASD or who are non-ASD. We did create a telehealth RapidFire where the research team directs the parents to conduct the test, and we would score the test. And then toddlers were divided into an ASD or non-ASD group. Next slide, please. So we were able to improve access with the RapidFire. Patients can get in and observed faster. And this model also applies to the telehealth RapidFire. Next slide, please. For the telehealth RapidFire, we had 86 toddlers, 15 were non-ASD, 71 were ASD. We compared their RapidFire score to their final diagnosis, and we determined cutoff scores, and this all correlated highly with the original RapidFire. Next slide, please. We have developed material for remote evaluations and a manual and scoring sheet that have been translated to different languages. And we are creating a course on the telehealth RapidFire, and we are looking at ways to disseminate this further. Next slide, please. We continue to study both the in-person and the telehealth RapidFire. So please visit our website for more materials and updates, and our email is also listed below. Thank you.
Wow, thank you so much, Valerie. So I'll start off with a question again. So I'm interested in knowing more about the training specifically for ECE providers. So being a former educator myself and being a teacher of early childhood providers, I'm really wanting to know when it came to administering the training for this tool, what was it like? How extensive was it? And can it be used as a primary prevention tool for centers and schools? So something that is universal for all, for them to give to all children.
That's a great question. Thank you. That is one of the main things that we are trying to work on right now is that dissemination. So we welcome any feedback as well if anyone has anything on that. So we are looking at ways to generalize this and kind of make it stand alone. As for the training, so for the original RapidFire, we do have workshops and we have a course on Blackboard that people can register for, and they have all kind of videos of administrations as well as the translated and original manuals and scoring sheets available to them at any time. So people can really be reliably trained within 3 hours, and then they're able to administer the test once they are certified within, again, 10 to 15 minutes. So for the telehealth one, again, we are looking for other ways to disseminate, but for now we're looking to try and incorporate the telehealth into the Blackboard existing course for the original Read-A-T. So essentially anyone with a prior experience with early childhood. We've had a number of different people from different backgrounds train on this. We've had NPs, physicians, PCPs, early intervention. So anyone with kind of an early childhood background can kind of get verified in administering the Read-A-T. So we're looking at how to incorporate the telehealth one into this as well.
Wonderful, thank you. So definitely having some comments about someone that's been trained and enjoyed it, said it was great. Wanting to know more about the work that's being done to validate it using the telehealth model. Any updates on that?
Yes, so we do have clear cutoff scores right now. We kind of just had our cutoff to get our final database analyzed and validated. So that is kind of where the project is headed now. So I think the next steps are really the rollout of the telehealth Read-A-T and kind of, solidifying that validation with the work of our team as well, and kind of incorporating the new training of the telehealth Read-A-T into the already existing model. That way it's more accessible for everyone and available for everyone to use in their clinics and in their practices as well.
Wonderful. I have a few follow-up questions. So when it comes to the Read-A-T, how has it been adapted, or will it be adapted to be culturally sensitive and relevant for communities of color?
Yes. So I think one of the benefits of the Read-A-T so far has been that it doesn't really rely on language. And it's a relatively inexpensive test compared to other testing methods that are available right now. So that kind of makes it available for underserved and underprivileged communities, and as well as the not relying on language makes it more accessible to others as well to be able to use. So for instance, I've administered some telehealth Read-A-Ts with parents where English wasn't their first language, and they were able to follow the prompts well, and we were able to get good measures and scores from the children. So I think that is kind of where it is right now. We are looking for further collaborations, from the community and within our team as well to, expand on the translations and to, really solidify that the methods we're using are valid for these different communities as well.
Wonderful, thank you. And then the last question I have, you had mentioned that this is in public domain. So where can it be found?
Yes. So the Read-A-T you can register for the Read-A-T on our website. I'll actually pop that into the chat box if anyone is interested in kind of registering for the course. So once you register for the course, then it's again available to you through Blackboard, and you can finish it at your own time. You have access to the materials once you finish the training course. So the scoring sheet, the manual are all available to you whenever you log back in. So the training is available to everyone once you go through that registration course, and then it's yours to use from there.
Wonderful, thank you. I think we've got all of our questions answered, but if anything else comes up, please type it in, and I'm sure Valerie will make sure to address it. I want to thank all of our presenters for the Rapid Fire Session A. This was a major task to not only be able to get your wonderful presentations up, but then to be able to communicate them in a very short amount of time. I know it's an immense amount of information, so kudos to you for doing it and all doing it very well. And now I'm going to turn it back to, I believe, our moderators, and we'll go ahead and go into our next session of our time together. Thank you.
Thank you so much to all of the presenters, Alice and Belinda and Jessica and Jennifer and Valerie, especially Valerie for jumping in at the last minute. And thank you also, Elizabeth, for facilitating that. That was a really great discussion and highlights of some great research. So we are going to move into Group B, the second group of rapid fire presentations. This particular group is focusing on the research nodes of community and lifestyle interventions and also genetics. And our faculty facilitator here is Carrie Caulfield. Thank you so much, Carrie, for being here. She's Assistant Professor of Pediatrics and the Director of Pre-Service Training at the Boggs Center on Developmental Disabilities at Rutgers University.
So thank you, Dawn. It's my pleasure. And I'm really excited to be able to introduce and facilitate the next several poster presentations, which I've had the privilege of previewing and I think are going to be very interesting and hopefully lead to a lot of good discussion. So first up, I would like to welcome Payal Khosla from the University of Arizona at the Sonoran UCED.
Thank you so much. Good afternoon, everyone. My name is Payal, and I'm here today to talk to you about sleep health among autistic students in higher educational institutions. Next slide, please. So autism spectrum disorder, which as we all know is a developmental disorder that's characterized by mild to severe impairments in so many different aspects of our lives, including but not limited to cognition, communication, and social interaction. And what we already see is that increased rates of comorbid physical and mental health concerns, including sleep problems. So anywhere from 40% to 80% of children and adolescents with autistic children and adolescents exhibit sleep problems. And the prevalence rate in enrolled students in higher educational institutions is anywhere from 0.7% to 1.9%. Next slide, please. And sleep is really important because, first of all, it's a dynamic physiological state that impacts so many different aspects of our lives. It's interactive and it's also bidirectional. So as you can see on the diagram on the right, there are multiple factors that can contribute to a sleep problem or a sleep behavior. And those same sleep problems and sleep behaviors can also impact the environment, our daily living, to name a few things. Next slide. And the way we measure sleep is through subjective measures such as parent or caregiver report or self-report of sleep, the habit, supplemented with a sleep diary, but as well as objective measures such as polysomnography, which is shown here on your left, which is the golden standard when it comes to looking at sleep. And then actigraphy is shown here on your right, which is like a Fitbit monitor that you or I would wear. Next slide, please. So when looking at the literature in sleep and ASD, we already know that sleep problems are prevalent in this population and they impact daily functioning, academic achievement, and even social interaction. But looking specifically into the college students, we see that there's some studies that are showing there's significant differences in sleep behaviors, such as longer sleep latency. But in other studies, we see that autistic college students are actually less likely to report sleep deprivation than their neurotypical peers. Next slide. And so these contradictory findings illustrate a need to look at sleep health in autistic college students, particularly using a mixed method design tapping into physical and mental health, academic performance, work, and social interactions, so that we can effectively translate and disseminate these findings to promote health in general, not just sleep health among autistic students and help meet their needs. Next slide, please. Thank you so much. I'm open for questions now.
So thank you so much for your work on this really interesting and I think important area. And so as in the last rapid fire, I'll kick us off with the first question and invite others to type their questions in the chat. So you had talked about some of the ways that sleep might impact social interactions. Has there been a lot of work done in that area? And can you elaborate a little bit more on sort of the ways that impact manifests?
That's a great question, Carrie. So when we're looking at different we have to first think about it in different autistic age groups as well. So in our studies, we want to focus on college students. And there is some research, but especially in the younger age groups, what we know is that if we're sleep deprived or we're not meeting good quality sleep, which is measured through so many parameters, we're tired during the day. If we're tired during the day, even our ability to make friends, to behave in a social setting, whether it's in the family setting or in the neighborhood, it's impacted. We're not performing our best. So in those social interactions, we can also actually kind of categorize it. Are we looking at the neighborhood? Are we looking just within our family? How are we behaving in that end? Or with our just ability to make peer, friends and peer relationships at school. So all of those are shown to be impacted in some capacity.
Thank you. And so Alice has put a question in the chat. She says, this is such an important topic clinically. What types of interventions would you suggest to improve sleep quality and sleep duration for autistic individuals?
That's a great question, Alice. So I think so my work actually with sleep focuses on other developmental disorders, and I'm just starting to get into looking at autism specifically. And this is very, interesting and a topic for me myself. I think when we're looking at interventions, the first thing we want to see is, what do people know about sleep even? Because I think it's just one of those, you need to have sleep. And that's what is parents know, caregivers know, and we just need to have sleep, but nobody's really focusing, or there's not so much that is looking at, well, what do people know? What's the basic perception of sleep? Is it really important? What do parents even know about whether their child has a sleep problem? And when we're talking into college students, especially, the college student setting is in itself a very new environment. And if they're away from home, they're bound to have sleep problems. So how are they just handling their own sleep routines, their behaviors? So I think the first intervention, I wouldn't necessarily say is an intervention, is just to get an idea of what is sleep and how is sleep important to them, what does sleep mean for people, and then from there kind of go into teaching them about sleep hygiene techniques. Like we know with some research already, you don't want to watch a screen before bedtime, certain periods before bed. There are apps out there to help us time our bedtime routine so that we are not doing high intensity activities before bed. So implementing those, but also getting a sense of what are people currently using and building off of that, especially in this age group.
I think that makes a lot of sense. And I think, you keep going back to the fact that your study is really focused on college age students. So have there been any number of studies that have sort of demonstrated the baseline typical sleep patterns for college students, which I might anticipate just in general might look a little bit different than, say, adolescents who are living at home or adults who have a more traditional sort of 9-to-5 work schedule?
You bring up a great point, Carrie. So that is what spurred our interest here in looking at sleep in college students, because we found only one study focusing on that population specifically. There are some studies of adults, but then just by the term adults, we are going beyond the college stage years and moving forward to the elderly population. So with even that, they've only looked at sleep using the sleep deprivation. And sleep deprivation plus college, the whole setting, it's a huge complex situation, as you can imagine. So what we need to do is look more to even get the baseline, because we don't have a baseline to figure out, are they actually sleeping more, worse, away from home, at home, with a roommate, without a roommate? Like, how different is it from their pre-college environment? And following up with them maybe throughout college to see how they improve, if at all, hopefully.
Well, thank you. I don't see any more questions in the chat at this point, but I invite people to go ahead and pose more if they occur to you. I think it's a really interesting area, and clearly one where there's still a lot of questions to be asked, and much still to be learned. So thank you so much.
Thank you so much for having me.
Okay. And so I think we'll go ahead and transition into our second poster in this area, Madeline Gillentine, who's a variant scientist at Seattle Children's Hospital, will now share her poster with us. So welcome.
Hi, can everyone hear me? Great. All right, so today I'm going to share with you my work in estimating the prevalence of monogenic neurodevelopmental disorders. Next slide. So a lot of the families that I've worked with, we provide a genetic diagnosis, and one of the first questions is, okay, who else has mutations in this gene? Because it's very important to establish, noise. Okay, but it's important to establish community around these particular genes because they can be so rare to have mutations in. And we know that recently there's been a lot of going on social media, including Facebook and Twitter and beyond, that have allowed families who have variations in the same genes to connect to each other. And while this is really important not only for, providing community for families, it's also really important for understanding how these disorders develop over time. And to date, there hasn't been an estimate of the prevalence of these disorders. And here we utilized a meta-analysis of data from the literature as well as our own cohorts to try to estimate how often these genetics occur among individuals with neurodevelopmental disorders. And so our goal is to provide an estimate of the prevalence of these monogenic disorders among individuals with autism and the broader population. Next slide. And so to do this, we were able to utilize information from about 47,000 individuals, 15,000 of which have autism and the rest developmental delay or intellectual disability. And from that, we were able to estimate the prevalence among neurodevelopmental disorders, as well as extrapolate to the general population using the estimated prevalence of these disorders provided by the CDC. Next slide. And we already know that the genetic contributions to autism are pretty confusing and very broad. And so of cases we see in the clinic, about half still don't receive a genetic diagnosis. About 20% are due to large chromosomal changes, and about 5% are due to differences in metabolism. And what we're going to be talking about today is this quarter of cases, or about 25%, that are actually changes to individual genes in the DNA. Next slide. And so to do this, like I said, we took our large cohort and compared this to the prevalence of autism in the United States over time. And from that, we estimated prevalence. Next slide. And I'm only showing you about the top 20 genes here. And if you zoomed real in, I'm sure some people would find their favorite gene. But we were able to estimate this for over 2,000 genes. And we can see that a lot of these are falling into the rare disease category, which is 1 in 200,000 individuals in the population. And this is for the United States, to be clear. While a lot of them even fall into this ultra rare disease category, which is less than 1 in 500,000 individuals. And so this is really highlighting that it's important to identify these individuals because they're so, so rare. And yeah, next slide. And while I was showing you there just the numbers for autism, we actually know from this that very few genes are autism specific. And so here's just a Venn diagram of autism in purple, developmental delay and intellectual disability in green, and neurodevelopmental delay broadly in blue. And we can see for all three of those categories, most of the genes overlap between them. So while we can estimate how common they occur among autism or among developmental delay, it's really important to understand that there's some differences between individuals that's causing slightly different conditions. Next slide. And of course, our study has a lot of limitations. This is likely an underestimate for most of these genes. And part of that is that we know that individuals with autism tend to have fewer molecular diagnoses due to a lack of testing. And genetic testing is often biased towards more severe cases. So this is really assessing a cohort that is autism plus other comorbidities, most likely. And finally, we know that these large cohorts are often missing some cases. And so, we're not able to get every single person. And so this is giving us a slightly lower estimate than we would expect in the real population. Next slide. So in the future, since we have this for over 2,000 some genes, we do plan to make this an available resource for families and clinicians to use, so we can provide at least some of an answer to how many people have mutations in this gene. And we also plan to continue to fine tune this prevalence estimate as more and more data becomes available. Next slide. And so with that, thank you. My contact information is on the slide, and I'm happy to share it in the chat. And if anyone has any questions, I'd be happy to answer them.
Thank you so much. I think this is so interesting, and yet I know so little about genes and genetics. And so I have a couple of questions that I'll start with. But first, just thinking more broadly from like a clinical applicability of this information, what do you think is sort of the major takeaway that we all can sort of take back to our own work?
I think a big thing is that while autism is very genetic, we know that, about 80% of the contribution to autism is genetic. That is extremely variable. And so, you're very unlikely to meet multiple kids with the same genetic mutation. And now on top of that, by understanding kind of how common these occur, we can go back to kind of the larger research organizations who are identifying potential treatments and say, look, this one's affecting this many people and it's related to this gene. So like, can we try to find commonalities between these for therapeutics? So I think those are the big things. And then I think just knowing that you're not alone in that mutation is really important. And so I think it's just a peace of mind thing as well.
Yeah, and I think being able to access your work to connect families if you're identifying similar individuals with similar mutations, I think would be a huge applicability of this. Yeah. So I'm gonna ask a couple of questions that I think sort of belie my lack of understanding about genetics. But you talked about that we know that there are a lot of genes that contribute to autism. And so what exactly do you mean by contribute?
Yeah, it's really hard to say, any gene mutation causes autism because autism is extremely heterogeneous. And so we say contribute mostly because it's like, okay, we know that this gene's involved in brain development, but there could also be environmental things going on, and that's why it may vary from person to person. And so, yeah, we say contribute, and because we know that, there's just looked this up the other day, but I think our estimate for how many genes are implicated in autism is like well over 1,000 at this point. And so it is plausible you're going to have multiple. And so, we can't say definitively, oh yes, this one gene is doing one thing and it's responsible. And genes are very active in cells. And so it just, in the brain, so much is going on that it may not even be because of the function of that gene. It might be related to another one that is impacted by that. And so we try not to be too definitive.
Sure. Well, thank you. That's helpful. So there are a couple of questions that have come in the chat. And so quite a few, actually. So the first one is about your plans for future dissemination. How do you plan to make this more accessible?
I'm open to ideas, but I imagine we'll have, a publication at some point. But I also want to make this an available resource on a website that I'm trying to build that will include not only this prevalence information, but also any links to other organizations or like family groups. So it's kind of a one-stop shop for, when you Google a gene, it will pop up and say like, okay, look, this is how many people have this. Here's their Facebook group. And like, here's some of like the scientific things we know about it. And so it's a work in progress.
Okay, thanks. Yeah. And Julian asks, how did you control for counting cases more than once?
Yeah, that is a fun problem. We do our best, but it is totally possible things are counted more than once. For most of the individuals in this study, we did have more information than just one mutation. So we were able to kind of compare and try to eliminate any duplicates. So to our knowledge, we do not have any duplicates, but I'm sure that's not 100% correct.
Okay, great. And I see the monument, so I'm going to pose one last question, but there are additional ones. I guess Carrie's question is, I know it's complex, but she would expect that multiple genes are impacted for many individuals. And so does your current analysis account for that?
Right. And for this, no, this is really looking at individuals who, as far as we can tell, have one mutation. We could go back to our data and try to identify all of those that do have like 2 hits. We just haven't done that yet. And that would also be valuable to know how many people have mutations in multiple of these genes. But that's just something we haven't gotten to yet.
Great. Thank you. Thank you so much. This is so exciting. And I think people are really interested in finding out more about this. So great work. Thank you. Okay, so I think we'll go ahead and transition into our third poster. And so I would like to welcome Felipe Avila and Jamie Bolander from the UC Davis Mind Institute.
Hi, everyone. My name is Jamie Bolander, and I'm here to present with my colleague, Felipe Avila. We're here to present on Black mother-parent advocacy development. Next slide, please. So our objectives in this study were to understand the role of spirituality and how parents of children with autism develop their ability to advocate for their child. And we also would like to use our findings to inform how faith-based interventions could be used in communities, and also to address the need for increased research concerning the Black community. Next slide. So our data was collected through qualitative interviews with 2 California mothers, and these mothers were Black, English speaking, have a child with ASD, and they were also peer coaches. Next slide. So to derive meaning from our data, we devised 2 codes. One was labeled as internal spirituality, representing one's relationship with God, and the other was external spirituality, representing one's relationship with their community. And our aim in this distinction was to see if mothers' personal spiritual practices or their social connections more informed their advocacy development. Next slide.
And so our results show that faith, belief, and God are important themes linked with the mother's advocacy development. And overall, we found more internal codes than external codes, which illustrates how the mother's relationship with God is more important in their advocacy journey. Next slide, please. And these are the 2 word frequency graphs that we use to analyze the data. A word cluster to understand the associations between the words, and a word cloud to understand the frequency in which the words appeared in the transcripts. Next slide, please. So we suggest that parents with children on the autism spectrum may benefit from spirituality-based support programs in their communities. We encourage that parents in advocacy groups develop strong personal bonds with each other, and we hope that these types of interventions expand the parents' skills in advocating for their child. Thank you so much for your attention. We look forward for the questions.
Hey, thank you both so much. I found this to be such a fascinating study. And I wanted to start with one broader question that has to do with sort of advocacy development. And so through this process, did you define that for the mothers you were talking to, or was it, did they define it as part of how they responded to the questions that were asked?
So the data that we use are from Dr. Morgan's dissertation work, and what she did was to understand how these mothers advocated for their children, just to simply understand like how they did it, what were their struggles. And when Jamie and we helped code this data as interns, and we saw that faith came up. It wasn't coded initially, but it came up in all of the transcripts, all 7 mothers. And we wanted to understand if faith and spirituality was a factor in the advocacy development. And our small case study did connect those 2. And what came up specifically for one mother, Ola, is that her advocacy development mostly came from her mother, from her, we call it the trustworthy agent of support. Mostly like her mother was her rock. And other than her mother helping her raise her child with autism and going through the whole medical process of getting the diagnosis, Ola's mother was also very religious. And so we understood through those transcripts, those interviews, that those two concepts were linked, were intertwined. And what we found, Jamie and I, is that religion was more of like an overview or a background that came up in the advocacy development. For example, we couldn't put it in the poster, but we did find a really nice quote that Jamie and I liked. It was from Hope, the other mother that we analyzed, and her quote was, "God doesn't call the qualified, but he will qualify the called," right? And I feel like I was my son's parents for a reason. And we really like that quote, mostly because we can see that her drive just to raise her child just came from her conviction, from her personal religion. And it was a very nice, like it encapsulates our research into that nice little quote.
Yeah, I thought the quotes were really compelling. So in the poster presentation that I got to listen to, you also gave some examples, but for everyone else, can you talk a little bit about what the types of interventions that you recommend might look like?
Mm-hmm. I'll go ahead and take that question. Mm-hmm. So we found more internal codes than external codes, meaning that we saw a lot of personal spiritual practices really informing the mother's ability to advocate for their child. For example, journaling in relationship to a spiritual practice, or prayer, or talking about spirituality with family members or loved ones. So any of those, like teaching parents to do those sort of practices, and most realistically, those sort of strategies would be taught in a church setting, as well as overall, there were lots of very interpersonal relationships that really helped mothers support their child. So having someone where it was almost like, I'm so called to this person, and we talk about very meaningful things, and they know me like a kin relationship, that those relationships were very influential to mothers as well.
Thank you. And so the community locus for the interventions then would be those centers of worship, which are those external, right, faith relationships, but trying to build the skills around those more spiritual, personal actions that really seem to support the advocacy.
And what we found when we're going through a literature, we found that parents who were seeking out support from congregations and the external part, they faced a lot of kind of backlash, or people from the congregation didn't really understand what autism was, or they didn't get the support that they wanted. So that's why we kind of aim our implication, our interventions into that part of the community, because if parents are religious and they're looking for help at their congregations and they're not getting them, then there's something not going correct, something that is lacking. And for one, that's what Jamie said, is to have kind of these groups of the church settings, but also it can come up with just like a Facebook group that people can connect and share the ideas. It doesn't necessarily have to be from the church setting, but having that spirituality as a common ground so that people can connect and understand and learn about what it's like. You know, the challenges of raising a child with autism is really difficult especially from what the mothers would say in these transcripts.
And I do want to add just one example from our data that I thought was really compelling of a mother kind of presenting a community-based intervention on her own. We had a mother who was saying, hey, there was a woman who had a child with autism, and she basically started a group in her church that was like this was my experience. Hey, I went through this in caring for my child. This is what it's like. This is why you might see my child act this way sometimes. And maybe those sort of interventions of just like a group meeting where people can really just share their experiences to educate not only other parents of children with autism, but just the spiritual community at large might be helpful.
Thank you both so much. It's so interesting, and I invite others to put questions if they have them in the chat. And I think we'll go ahead and transition to our final poster for this rapid fire session. So now I would like to invite Carrie Staples, an assistant professor from Texas Women's University, to share her poster with us.
Thank you. The research I'm presenting today was conducted when I was a postdoc at the University of Michigan in collaboration with Leah Ketchinson from Wayne State. And the purpose of this research was really to understand health indicators beyond physical activity that may influence the health and weight status of children with ASD. The study included 48 children with ASD and 49 children with neurotypical development between the ages of 3 and 9 years. And to examine age-related differences in a variety of health indicators, we divided children into 2 groups reflecting early and middle childhood. Next slide. The left of this slide looks at weight status, where the dark gray and black at the bottom reflect the percentage of children who are overweight or obese. And in this sample, 55% of 3 to 5-year-old children and 44% of 6 to 9-year-old children with ASD were overweight or obese. And this was compared to 9% of children with neurotypical development. On the right side is the number of minutes spent in moderate to vigorous intensity physical activity, and this was an objective measure. And in the following graphs, children with ASD are in blue and children with neurotypical development in light gray. So 60 minutes of MVPA is referred to as that magic number for maintaining health benefits. And although there is variability within each group, the median time for all 4 groups reflects participation in more than 60 minutes of MVPA, which is contrary to the number of children who are overweight or obese that we can see on the other side. Next slide. And just quickly going through some of the results, if we look at locomotor and ball skills, within each age group, children with ASD perform fundamental motor skills with significantly less competence. Next slide. And we have similar results when we examine 4 measures reflecting cardiovascular and musculoskeletal fitness. In both early and middle childhood, children with ASD demonstrated lower levels of fitness. Next slide. And finally, quality of life is not often considered an important health outcome for children with ASD. With increasing age, it becomes more so, but our results suggest that it should be emphasized in early and middle childhood. It was unexpected to see that children with ASD were already experiencing significantly lower levels of both physical and psychosocial quality of life at 3 to 5 and 6 to 9 years. Next slide. And the key points to take away from this presentation are that in addition to disproportionately higher rates of overweight and obesity, children with ASD experience poorer health across multiple health indicators. And significant disparities are present already by 3 to 5 years of age. So what we're currently doing to improve the health of children with ASD is not working, and we really need a multifaceted approach that is embedded within the community in order to make that change. Thank you.
Thank you. I think this is a really interesting presentation that builds really well on the first session that we had.
Yes.
And I think aligns very well with those findings. And so,
can I just interrupt before I didn't have room in my 2 minutes. Both of these studies and the children included here were both intended to be part of a longitudinal study, and then 2020 happened. So we only have our baseline data. And then in my in my actual presentation, I shared a little bit about that second study, but we are looking for going back for more funding now that I'm at a new university and replicating this, but over 18 months and longer to really see how these health disparities kind of unfold.
And in your poster presentation, you talked a little bit about an intervention. And so I want to invite you as my first question to just talk a little bit about the intervention that you think will be helpful.
Well, if we look at the model that I talked about or kind of designed this study around that is included in the larger presentation, it really shows that fundamental motor skills and motor competence is actually the driver of much of physical activity participation in early and middle childhood. And so although in that model that's been tested extensively with children with typical development, they say age is that driving factor. But in my research, and in the work of those of us in kinesiology, we really think that fundamental motor skills are the driver, not age. And so our interventions are targeting fundamental motor skills, and we do see that we can make improvements even in young children. And my actual PhD research showed that, and I did in this presentation too, that children with ASD perform fundamental motor skills with similar levels of competence as children approximately half their chronological age when we compare to neurotypical development. And that has huge implications for participation, also from the social piece, which we were talking about earlier. If children don't have the motor competence or social competence, how do we expect them to be successful in physical activity and group-based activities? So,
yeah, that was really a striking finding as I reviewed your larger poster. Do you have any thoughts about what that might be suggesting?
Sorry. Well, it comes down to opportunities, and although motor skills and motor competence has been kind of on the forefront, we're saying we see these differences as early as 6 months of age. Motor has not entered into the realm of early intervention just yet. But when we think about what being able to perform some of these fundamental motor skills early in development, what opportunities those afford in terms of interaction with others. So really focusing on those early motor milestones and fundamental motor skills as they pertain to participation in physical education, physical activity, playground, play. Yeah.
Oh, that makes a lot of sense. That makes a lot of sense. Thank you. I don't see any questions in the chat at this point. I'll invite people to type them in, and I'm sure Dr. Staples will be able to answer them. I want to thank all of our presenters for some really exciting work, and I look forward to hearing more about the continuations of all of these projects. And I thank everybody for your attention to this rapid fire poster session. So thank you so much.
Thank you, Carrie, for facilitating Group B of our rapid fire presentations. And thank you also to the presenters for sharing your research, to Payal and Madeline and Jamie and Felipe and Carrie. We are going to move forward to the plenary session and for the closing plenary. And for this,